So we were talking about this proton pump, and we talked about how it worked in the stomach and why it's so effective. But one of the things that we never mention is that this is a proton pump inhibitor, and it inhibits the proton pump in all of your cells, not just the stomach cells, but every cell in your body. And each proton pump has a different function, and the function of the proton pump in the endothelial cells, which line all of our organs, is to pump the garbage out of the cells. So now these cells are not pumping garbage. We're living in a garbage dump if we take that medication. And it causes those cells to die early, and we call that early senescence. And so we think that may be the cause of early dementia, heart disease, and kidney disease. So, and now if you look at the label, you're not allowed to take this for more than 2 months. And people have been on it for years and years and years and years because it's so effective. Just because they think reflux is a very, very, very common symptom, but it may not be from acid reflux, it may be from some other issue. It could be related from an intestinal problem, it could be from gallstones, it could be from an infection in the lining of your stomach, and that infection is very dangerous. And so if you have symptoms that you think might be reflux, you should first of all find out right away by going to someone who's knowledgeable about the disease and having that taken care of. Some few basic diagnostic tests, like to start with an endoscopy and a barium swallow. If it turns out that you have GERD, then you should be on a PPI for a couple months while you try to change your lifestyle, lose your weight, raise the head of your bed, stay away from carbonated beverages, lose a few pounds, quit smoking, quit drinking, quit living life to the max, and live in a relatively conservative fashion until everything gets better, then get off the Prilosec or the PPI. And once you're off the PPI, then you go on with your life and see how you do. If you fail or you have to be on that medicine continually, well then something needs to be seriously done. If you have been on the medicine for a long time, you need to very well try to get off it. And if you can't get off it, then you need to seek help about having some kind of if there's an anatomical problem, to have that anatomical problem corrected. One of the things that I see since I've been doing this surgery is that many times the anatomical problem has been caused by some blunt torso injury. Nowadays, all of our cars have airbags, all of our cars have shoulder harnesses. In the old days, people that had a head-on collision at that high speeds were killed, and they didn't survive it. Now they live through it, and the problem is that when they have that injury, it pushes your chest is protected by your ribs, and so that pushes all that material up into your stomach, up into your chest through that tiny little hole, and if it tears that hole, then now you have the beginnings of an anatomic disruption of the reflux barrier. And I see that in motor vehicle accidents, trauma of some sort, blast injuries, soldiers that have been injured in Iraq, and those will not get better typically unless they're operated on. Anything that delays the emptying of your stomach will cause more reflux. If you take medications that have narcotics, for example, that delay the emptying of your stomach, you'll have more reflux. If you smoke cigarettes, it relaxes that valve, you'll have more reflux. If you eat a very fatty meal, that fatty meal delays the emptying of your stomach and you'll have reflux. There are some people who have problems related to tomatoes and tomato juice and those kind of things, but in reality, the acid, when you eat anything, it lowers the acid content in your stomach. So mostly it's going to be fatty meals or fatty foods that cause those kind of things. And then there's individual people have certain items that they can't handle, and typically peppermint is one thing that relaxes that sphincter that causes reflux. Typically what I do is I try to prove that the patient has reflux. So when they come in, I talk to them and I take a history and I make sure that what their symptoms are going on correlate with acid reflux. And if I think that's their issue, then I will order to start with a barium swallow so I can see the movement of the esophagus, the muscle, to make sure that it's working. I might even be able to see reflux. then an endoscopy where I will evaluate the muscle function of the esophagus, the junction between the stomach and esophagus, make sure it's not misplaced, the size of the diaphragmatic orifice, make sure they don't have any other issues in their stomach like ulcers, infection, outlet obstruction, those kind of things, inflammatory bowel disease or some other issue, some other medical problem. Once that's done, make sure they don't have any precancer cells, which reflux patients get because of the reflux, and so we try to rule that out. And then prior to the surgery, if I'm not clear, I still may do what's called a Bravo. We put a capsule in the esophagus and it measures actual reflux, how much reflux the patient has, and then a manometric study that shows how well the function of the muscle works. If they've done all these things, tried medical therapy and they've failed, they've changed their lifestyle, I would not recommend them to be on the medicine for very long now that the endoscopic repair is here. In the old days, the last ditch effort that you would do would be a Nissen fundoplication because you would then be condemned to not ever being able to belch or vomit again. And you'd be bloated many times, uncomfortable, and there's absolutely nothing we can do about that except redo it, and then it never works well. So now that the endoscopic repair is there, it is very, very safe, and it is very, very effective, and it doesn't have any of these long-lasting side effects, and 95% of those patients are off the PPI in about 2 weeks. I would recommend an endoscopic repair and possibly a laparoscopic closure of the hernia if it's intact. And those would be my recommendations. It is a recreation of the anatomic defect there, similar to the Nissen fundoplication without any of the side effects. It's extremely safe. We endoscope the patient like they've had the endoscopy, and with that endoscope there's a device that recreates this valve through some manipulation of the tissue and suturing of that tissue through this device that it permanently fixes it below the diaphragm and stops the reflux. And it is an overnight stay. They stay overnight and they're on a special diet for about 6 weeks, and then they go on about their business. If someone has a hiatal hernia, yes, we typically do that at the same time. It would require a laparoscopic procedure at the same time as doing a TIF, but the overnight stay is the same. The patient doesn't feel any difference really. It's an overnight stay, they're on the same diet, the same restrictions, and the results are as good, if not better, than just a straight TIF. And the TIF results are comparable, if not better, than a Nissen fundoplication. You know, we have patients that either are improved, or they're happy, or they're very happy, or it's a life-changing thing. There are people that don't even realize that they're not sleeping all night long, and this after the first week, the first day after the surgery, they sleep all night long. They don't even realize that they haven't slept. And so as a physician, you know, we all became doctors to make sick people well. And these patients that have GERD are actually sick. They're aspirating at night, they're coughing, they have a tendency for long-term COPD, that because this material comes into their lungs and destroys their cilia and the lungs get destroyed, they have chronic sinus infection, they're on this medicine that causes osteoporosis and different calcium issues. And so they're actually very, very sick. Can get a pre-cancer condition from the reflux. And to stop that with this simple operation, changing their lives and protecting their long-term outlook is miraculous. And so as a physician, it's very, very satisfying.